Kia ora koutou, everyone. Just waiting for people to join us. We've got people coming in all the time. Greetings to you from Ottawa as well. So welcome, everyone. I'm Dr. Sarah Schoenberger, the Head of Research at the Neurological Foundation, and really excited to have Prof. Jon Stone with us tonight talking about functional neurological disorder. I'm just going to start with a quote that I have on my office wall at work that just really shows what we all do at the Neurological Foundation, in Jon's research as well, and all of the patient care and support community that wraps around patients as well. Ihara taku toa, e te toa takatahi, engari he toa takatini. My strength is not as an individual, but as a collective. So as you can see, your camera and microphone have been automatically turned off, so you'll be unable to turn these on and we can't see you or hear you. We invite you to use the chat and Q&A functions to communicate with us during the session, and you'll find these functions at the bottom of your screen. To use the chat function, click on the icon that says chat and it will open a pop-up window. Only the panelists can see what's in the chat. You can use the chat box to ask us for technical support questions and we'll do our best to help you. If you have any questions about tonight's topic, please use the Q&A function. Click Q&A at the bottom of your screen and it will launch a pop-up window. The questions are visible to all attendees and also to the hosts. If you want to remain anonymous, tick the Send Anonymously box, and then we can't see the name of the person who submitted the question. Because we have a limited time frame and a lot of people joining us tonight, which is fantastic, we might not be able to answer all the questions tonight. So we ask that all questions please be kept to the topic presented. And also, we can't answer any personal medical related questions that people have, so just keep your questions general and brief, please. At the conclusion of the session, we will end the Zoom for everyone, and then at a later date, the recording will be available in our lecture library, and the team normally have that up reasonably soon. So now we'll get to the interesting stuff, and I'll be introducing Prof. Jon Stone. So Jon is a professor of neurology at the University of Edinburgh and a consultant neurologist with NHS Lothian. He's published over 350 articles and has won the Gene Hunter Prize for Nervous Disorders in 2014 and the Royal College of Psychiatrists President's Medal in 2017 and the American Brain Foundation Ted Burns Humanism in Neurology Award recipient in 2020. And he's a recipient of the Association of British Neurologists Lord Walton Lecture Prize in 2022. So it's just such an honour to have Jon with us tonight, and we're all really looking forward to finding out more about functional neurological disorder. So welcome, Jon.
Thank you very much. It's a real pleasure to be here. I'm just going to share my screen. Make sure I'm sharing sound. There we go. So have you got me there okay, sharing?
Yep, that's great.
Great. So I was just talking to Sarah and Manuel about the fact that I've got a special connection to New Zealand because I worked in Hamilton as a junior doctor in 1996, 97, and also came as a medical student actually into Whangarei and just in New Zealand for a couple of weeks for the first time since then, just last month. So it was lovely to come back and travel around South Island. And I was speaking about FND to the Physio NZ meeting. So I'm having a very NZ autumn here. So that's great. So I'm going to speak for about half an hour, something like that, 35 minutes about FND. I'm going to give you a sort of overview of it. I know appreciate some people here will know a lot about FND. Some people may not know much about it at all. A bit about the history as well, because it's come from a unusual sort of place really in neurology. So I'll take you through that, but looking forward to the Q&A at the end. So I'm a neurologist, and I do neurologists, as you know, see all kinds of neurological conditions. I still do lots of general neurology. I do on call, and became interested in FND in the 1990s, probably round about when I was coming to New Zealand, actually, and have been doing research and seeing patients ever since. So I thought we'd start with a patient. This is Rachel. She's a university student, referred to me a few years ago. And what had happened to, she'd woken up one morning with weakness down the right side of her body, a bit like a stroke, but she was rushed to hospital, investigated, and didn't have a stroke. Scans were all normal, but she had all the disabilities of someone with a stroke. And this is her just talking.
In an ideal health service, all doctors and professionals would be actually made aware of this. We wouldn't be treated as though, not like we're faking, but almost like as though it's not real. And that doesn't really help us, because we're thinking, oh, what's wrong with me?
So it's interesting what she says there about treated like, not like we're faking, but like it's not real. So sometimes a lot of people with FND find themselves in that middle ground because their tests are normal. Clinicians have historically, said, well, what is this? Is this a real condition? Just because we can't see it on the scan, and I'll come on to explain why you can't see it on the scan later. So when we're talking about FND, functional neurological disorder, what we mean is this is one of the many functional disorders that occur in medicine, and they're actually really common. And the opposite of a functional disorder is a structural disorder. So it's not, as some people have sometimes say, is an organic disorder. Human beings are 100% organic, so that you cannot have a non-organic disorder. It's not possible. The opposite of, but these are disorders of brain function, and I personally would include migraine in that. I have migraine. I think that's one of my functional disorders that I have. Whereas a structural disorder would be something like brain tumor or MS that you can see on a scan. One way of thinking about that is that these are disorders a bit like software of the brain. The programs that the brain is running have gone wrong, rather than the hardware, there's something burnt out or damaged. And if you're not into hardware and software, it's a bit like a piano that isn't broken, but it's badly out of tune, is another way of thinking about it. So I put here functional disorders, everyone's problem, because throughout medicine, people have chronic symptoms which are persistent, which relate to these functional symptoms or disorders, and they're really, really common. Studies in primary care and secondary care show that incredibly common, but very unrepresented in textbooks, training, research. They've kind of been ignored. And FND refers to the kind of symptoms that a neurologist would typically see, like seizures, weakness and tremor, maybe cognition and dizziness as well. It doesn't refer to chronic pain, which you can see there as well, or irritable bowel, but those problems and fatigue, those problems are really, really common in people with FND. So this does cause quite a lot of confusion. People often have a chronic pain syndrome, fibromyalgia, and FND, although they probably have very similar mechanisms. So this is not a new condition. This was well described in the 19th century. It has a difficult and stigmatized history. So it would have, in the 19th century, actually it was called functional nervous disorder, but it was also words like hysteria were commonly used, which are obviously very pejorative and difficult to bring up. But people wrote a lot about it in the 19th century, and actually wrote lots of very sensible things about it as well. And here's some pictures of people with this disorder back then. And it was interesting that it was often considered a disorder mainly of women until World War One, when it was found that huge thousands of soldiers were getting shell shock, initially thought to be due to the effects of blast injury, and some of it probably was, but there were also patients who definitely developed FND related to the trauma of being in war, and not just psychological trauma, but physical injury as well, which is a potent trigger for FNDs, and I'll be talking more about that later. And then what happened after that, particularly after World War One, that it sort of morphed into a condition where people were focusing really entirely on psychological factors. So Sigmund Freud came along and called it conversion disorder. The idea was that patients were converting a stress into a physical symptom, and this was the dominant model that we had for this condition over the whole of the 20th century. It's a model that I've fought to change. I think it's not the correct way of thinking about it. That's not to say that psychological factors are not important in many patients, but it's, as I'll explain later, it's just one cause. So what we're trying to do with FND is move it away from thinking about it as purely a psychological condition, to one that sits at the interface between neurology and psychiatry, and where the brain is important as well. And people have difficulty with that because they're used to things being either neurological or psychiatric, and here's a disorder which doesn't fit in that box. This was me 20 years ago with my wife and Pam and our two kids. And when I was training in neurology in the UK and probably New Zealand as well, this is what people with FND like Rachel were typically told. There's nothing wrong, got a psychological problem, your tests are normal, isn't that great? And often goodbye. So that's what happened to Rachel, actually. She was seen by a neurologist, told she had FND, and discharged. So, and I thought, what's going on here? You know, there are people, these people are really disabled. It's clearly a genuine problem. And I was struck by what a poor explanation it was to say to people, you've got a psychological problem, you must have been stressed. When actually many of them couldn't, you can't, as many patients with FND don't have an obvious stress. So it's been a difficult historical journey for FND, and it's still difficult. I think we're still dealing with that legacy. It's still treated in different ways to other conditions like MS or stroke, even though it has exactly the same symptoms. This is a survey from FND Hope, showing how often patients with FND have felt dismissed or disrespected when visiting a medical professional. And I just don't think you would see those sort of numbers in conditions like MS and epilepsy. So this is sadly where we were in the 1990s, a condition that didn't appear in textbooks. So actually, psychiatrists tended to think that FND was a diagnosis that was probably wrong when it was made, that neurologists were just missing things. It was considered psychological. Neurologists often did have a suspicion that people with FND were faking or malingering. And I'm sorry that this is probably quite distressing for some people listening to hear this, because they may have had these experiences, but it's the truth of this disorder, of where we've been and why things remain so bad for FND. And it was I'd often hear that people, well, it's best just to tell the patient it'll probably get better. Well, you can see with Rachel that didn't happen. Someone said, you've got FND, it'll probably get better. Well, it didn't. That was me seeing her a year later. So all of these things are wrong, really. It is common disabling. We can make the diagnosis. It's not a diagnosis of exclusion. That's really important. This is not a diagnosis you make just because scans are normal. It's both neurological and psychological in varying degrees in varying patients. It's definitely not malingering, and treatment can really help. So we were we were just people were just completely wrong about FND, I think, in the 1990s, and things are changing, but obviously these things take a long time. So how common is it? This was a study that we did across Scotland, nearly 4,000 new outpatients. And what we found was that about 1 in 6 patients had a functional disorder of some kind. And so really not rare at all. One of the commonest things that we were doing. So why was it not in the textbook? Why was it not in the curriculum? And we've also shown that you can make the diagnosis as reliably in FND as you can for other conditions like migraine and Parkinson's. People do get the diagnosis wrong sometimes, and that's obviously bad whenever that happens, but it happens in both directions. So there are lots of people diagnosed in the past with epilepsy who actually had FND, epilepsy and MS, and then occasionally the other way around. So people are diagnosed with FND and it turns out to be MS, but actually more commonly the other way around. So we've done a few studies there showing that misdiagnosis is pretty rare in modern studies. That doesn't mean we should be complacent about it. And we're always finding out new things as well about the brain and the body. So I want to talk a little bit about this diagnosis of inclusion, which is really important, and because where people were making this diagnosis in the past by saying, look, here's your MRI, it's normal, or your EEG is normal. Quite reasonably, I think patients would say, well, just do some more tests. You haven't got to the bottom of it yet. That's not how you diagnose it. You're looking for specific features that only happen in FND. And the features of FND actually tell you about the nature of the disorder as well. So here's Rachel again. And what I'm demonstrating here is a sign that we use in neurology called the hip abductor sign. She's got weakness of her right leg. And what I show in this video is that when she's trying to make the movement, she can't do it very well. The voluntary movements are impaired. But when I ask her to move her good leg, the movement becomes back to normal briefly. So the automatic movements are okay, but the voluntary movements are impaired. And that's telling you something really interesting about the disorder and also how we might go about treating it. So I'll just let this video run. You'll see that I explain the sign to Rachel as well. So can I just get you to push against my hand here? We can see that when we do that, you're stronger than I am, and I can't push that knee in. And then let's try and do the same thing with this knee. So stop me from pushing in, push out as strong as you can. But I'm winning there, pushing your knee in. Let's go back to this side. I want you to push out again as hard as you can. Really stop me, push, 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 push. Now when we do that, we can see that actually what's happening over on the right side is that it's become much stronger and I can't push the knee in now. So it's brought out the automatic movement. I don't know how easy that was to see, but these are often light bulb moments where people can see that there's a leg that they were not able to move themselves, but using these sort of maneuvers are almost like tricks really, but tricks that I share with the patient. Using the maneuvers, we can demonstrate the potential for normal function. So and that shows that it's not due to damage, it's due to the way the brain is communicating with a limb in the case of paralysis. And then for all of the different symptoms that people with FND have, there are different clinical features. This is someone with quite severe functional dystonia. You can get a foot that looks like that in other conditions, but this particular appearance is quite typical of functional dystonia. I'm asking this patient to close their eyes and tell me what the foot feels like. When you look at the foot, you can see that it's bent, obviously.
Yes.
Yeah. Can you just close your eyes for me now? And just tell me what that left foot feels like with your eyes shut.
It feels like it's straight.
Okay. It feels completely straight?
Yeah.
Okay. And then when you open your eyes and you look at it again?
And then I can see it's bent.
Yeah.
Although...
So is that a strange feeling, that difference between...
It feels strange because although the foot's bent and I know it's bent, when my eyes are shut, it's straight.
So it's weird, isn't it? How could you feel that it's straight when it's that bent? And it's because there is a problem with the patient's brain in terms of the map of their limb. So the brain is predicting and telling the person that their foot is straight and that that's the normal position. So if someone tries to bend it straight, it's a bit like if I was to bend your foot outwards, you just think, well, that's not the right position. And often patients, you put them in front of a mirror, are often shocked at the actual position that the feet are in. I haven't got videos of seizures because that can sometimes be upsetting for people. But again, when we see a functional seizure, we're seeing a whole set of characteristics of functional seizures, such as the eyes being closed, or the type of movements, how long they last for, what happens to breathing, which are typical of functional seizures. So it's not about the fact that it's not epilepsy. It's about the fact that it looks like FND. So what about this issue of it being neurological and psychological? And here we've got a bit of a conundrum to sort out, because when people say to me, is this a neurological or a psychiatric condition? Is it in the brain or the mind? My response to that is the wrong question. That is not even a question to me that makes sense from a neuroscientific point of view. So as I mentioned, this word non-organic that people have often used historically to describe this problem. And I wrote this article about why it was such a ridiculous word. And it's because it's just impossible. So we've got these pictures of these turnips, because you can't have a non-organic turnip. It's unavailable and philosophically impossible. And just the same way, human beings are 100% organic. How can a 100% organic human being have a non-organic condition? Doesn't make any sense. We suffer from sort of what philosophers call dualism. There's a sort of idea that goes back hundreds of years, that the mind and the brain are kind of different things, and it permeates throughout our language. But in fact, everything's going on in one organ, the brain, and there isn't a psychological bit of the brain. It's all weaved together. Someone show me the psychological bit of the brain. There isn't one. So is FND happening in the brain? Of course it is. Where else is it going to be happening? And we are discovering whereabouts in the brain things are going wrong in FND. And some of the things we're finding make sense of the symptoms. So here's a study, quite a old study now, from 20 years ago, showing some areas of the brain that were not working very well in people with functional sensory disturbance. So one half of their body doesn't feel right. And we show that there's changes in the brain on the opposite side, which improve when the symptoms improve. So yes, the brain is not functioning properly. So it is going on the brain. That doesn't mean as well that we shouldn't think about the person who has it and the things that have happened to them and how those things may have changed their brain as well. The other way of thinking about this condition is a disorder of brain prediction. And just so what we've learned, particularly in the last 10, 20 years, is that the brain doesn't work necessarily in the way that we think by just sensing things and then telling our brain what's happening. It works by predicting the world around it. So when I pick up this mug, my brain knows how heavy it is, and it predicts that in advance. And this short video here is an example of how our brains predict things based on where our attention goes. So I'll just let you, this video plays and repeats. So just have a look at those words, green needle and brainstorm. And it's exactly the same video. You only really hear the word that you're reading. So your brain is pushed towards hearing a certain phrase by what you're reading. Now, I'll just pause it a sec. If you now decide, if you close your eyes and decide in advance whether you're going to hear green needle or brainstorm, just see what happens, okay? So close your eyes and just decide whether you're going to hear green needle or brainstorm. People generally hear the phrase that their brain, that you've predicted in advance. So it's an example, it's a little window into how the brain works. And if you want to read more about this, I really recommend this book, Experience Machine, How Our Minds Predict and Shape Reality. It's a kind of really different view of how the brain works. So FND is telling us something really important actually about how the brain works, and it's different to what many people think. And this helps explain a lot of conditions that seem a bit weird. So in phantom limb syndrome, people feel a limb that isn't there because their brains are strongly predicting that the limb is there. And that prediction outweighs any sensory change that they're getting from the leg, or even visual change to say that the leg isn't there. And in FND, we think probably what's happening is the brain is predicting that the leg isn't there. So it's kind of the opposite of phantom limb. So it predicts the leg isn't there, and even though it is, and so you can't move a limb properly that is not properly connected to your brain. What about stress and previous trauma? Well, that is relevant for many people with FND. We know that about people with FND have 3 times the risk of having had bad things happen to them, both in childhood and adulthood. But those things, of course, are common in the population. And there are many people who have those experiences who don't have any health problems. So they're risk factors, and they're important because they help us understand why some people who've been experienced threat in their lives tend to have their brains respond to that by disconnecting, basically. And then when they're older, sometimes they get another threat, like a physical injury or an illness, and that leads to vulnerability to disconnection as well. So it is relevant, but it's a bit like, does smoking cause stroke? Well, yes, it does, but you wouldn't say that everyone who has a stroke must be a smoker. You would ask about smoking, and for some people it's relevant, and for some people it's just not relevant at all. Actually, having another neurological medical condition is just as strong a risk factor for having FND. So if you've had the experience of having a blackout from epilepsy, or you've got mild MS, or something, even things like carpal tunnel syndrome, the experience of something new, or perhaps after infection, can lead your brain to, some people's brains develop this strong brain prediction of a symptom, which then becomes true. And it's happening at a level in the brain that they can't reach down and change it. It is actually happening, needless to say. So this is a bit of a more complicated picture, but just in terms of the full picture, this is a slide from one of our papers on FND showing how it's complicated. There is not, if anyone says to you, oh, it's just stress, okay, it's not. Here's why. There's a whole load of things going on, including probably some genetic risk factors and endocrine, autoimmune stuff that predispose people. And then there's often a triggering event, like an injury or migraine or brain injury, or panic attack. And then there's other things that come along with it that people often have, things like anxiety and depression, but there's plenty of people with FND who don't have those things as well. And then things are made worse by being in a situation where the health system doesn't understand FND. So I'm going to send you a link at the end where if you want to look at this in more detail later. It's not malingering, it's not faking. And we wrote a paper called that, Why FND is Not Feigning or Malingering. And it's not just because I meet lots of people where it's obvious that they have a genuine disability. It's because there's a whole load of reasons why. This is a condition that's looks the same now as it did over 100 years ago. The clinical features are exactly the same. And there's lots of neurophysiological reasons on brain scans and other neurophysiological tests why it's definitely happening, why there are things that are going on here that you couldn't possibly know how to feign. I wouldn't know how to feign some of these tests in the bottom here, even if I tried. So the brain is not working. And what about treatment? Well, we showed that treatment's needed. People often ask, what's the outlook for FND? It's really varied. So there are people who have it for a few hours or a few days, it goes away. There are people who have it for 20 years. And we showed in this study with people with limb weakness that actually symptoms often do remain over a long period of time. But this was a group of people who didn't really have focused treatment. So we think we can do better than this. I personally believe that knowledge is power in FND, and understanding your condition doesn't make it go away, but it's an essential platform for the next step, which is trying to retrain your own brain to improve symptoms. So I made this website for people with FND about 15 years ago now, because there wasn't any information at all. And there's an app for it as well. And there's a thing on there called the FND formulator, where you can explore some of your own potential causes. And everyone's just a bit different. Everyone has a different route into FND. No two patients are the same, I would say. There's lots of videos on there that you might want to explore to understand FND more. And everyone and people have very different symptoms. So some people just have seizures, some people have tremor, some people have mixtures of things and pain as well, even though pain, as I've said, is not an FND symptom. But a website alone is not going to make you better, and I absolutely sympathise with this post from FND Action. Many doctors think this is the only treatment for FND. It's not. And if people are just getting a website and saying goodbye with a disabling condition, that's not good enough in my view. So what is the other treatment? Well, at the moment, the treatment is predominantly about rehabilitation. It's about using therapy to try and retrain the brain. And we've developed these consensus recommendations for physiotherapy and occupational therapy, speech and language therapy, and psychological therapy. It's a multidisciplinary treatment. So whereas before it might have been, oh, you go and see a psychological therapist. Now it depends what symptom you have, what treatment's like to help you. If you've got problems with walking, then FND-focused physio is probably where to start. If you've got seizures, then psychological therapy, which works in a similar way to psychological therapy for panic attack, can be a place to start. There's obviously a lot more to management than that. There are symptomatic treatments for different issues that people have. And I'll talk in a minute about other things on the horizon. I wanted to share with you Miranda's story. So Miranda, this is a video that you can see on the website. Miranda had a functional gait disorder, which she found physiotherapy helpful for.
My mum was there filming at the time, and she thought that it was crazy. And then he just made it faster and faster, and that's when we discovered that I could run. I could go quickly, but not slowly.
So that might seem really odd, that somebody could not walk but could run, but it does make sense in FND. So Miranda's walking program was kind of corrupted, the software of her walking program, but the running program wasn't. So she was able to use running as part of her treatment. Obviously, not everybody can do that, but it's an example of how for FND, you need to do something different. It's not the same physio that you would use for somebody who's got a stroke, for example.
Sam and I.
And this last bit just shows her after about 12 weeks of treatment, she was in depth conversation with her boyfriend and realized that she was walking normally again. Probably her brain was distracted, and so that promoted the automatic movement.
Sam and I, we were in depth conversation, and then it wasn't until we were halfway down the street that we both realized that I was walking like normally.
That is a miracle.
And my biggest fear then was to stop walking. I just kept walking because I was like, if I sit down and stop, what if I can't walk again?
So, yeah, so I would really recommend that film. And I don't want to give the impression that this is. I'm trying to sit in the middle here. So we are. Physiotherapy is important, but so is psychological therapy. This is Kinjal, he's a psychologist I know in India. He's doing great work there with people with FND. untangling the sort of web that I've shown you about why people get FND and looking at ways to change the brain through talking. And remarkably, that is possible. This is Claire Nicholson, who's an occupational therapist in London, who's led on occupational therapy for FND. Occupational therapy is very well suited to this condition because it's about focused on activity and actually doing things and improving limitations in life. This is Jan Baker, who lives in Sydney now, I think, who led on our speech therapy guidelines. Again, the speech therapy is different for FND to what you would do for other things. People often have pain, and there's a lot of information about pain there and what we know about pain now in FND. Most chronic pain of actually in any pain clinic relates to something called nociplastic pain. So the volume knob in the pain pathways is turned up. It's turned up at a level in the nervous system that people can't just reach down and turn it down again. So they are in pain. It's really happening, even though the pain is coming from the brain. And I really recommend this movie by Lorimer Moseley in Australia to help understand how is it possible that chronic pain can arise mainly from the brain. Some other things I just wanted to tell you about. This is a book called FND Stories, which has a number of personal and professional experiences of FND, came out earlier this year. There's a graphic novel here about someone with functional seizures called Not There. The My FND app by a colleague, Chris Simeon in London, is also really good, I think. So we're getting more resources. We've turned things around. And so where are we heading with FND? Well, one of the most impressive and helpful developments, I think, in FND has been the development of a number of patient-led organizations around the world. We absolutely cannot do this unless we do it together, health professionals and patients. And I've certainly learned a lot working with these organizations and individuals online as well. Particularly if you want a sort of deep dive into FND history and some of the things I've been talking about, I really recommend this person, FND Portal, who wrote this essay about his own experience of incredibly delayed diagnosis of FND and how he's made sense of it in terms of the history, the neuroscience. It's a brilliant read. This was FND Portal speaking at our Boston meeting in 2022. He got a standing ovation from the audience. I think it was the only standing ovation of the meeting. So a real turnaround of how health professionals are kind of treating and respecting people with FND compared to the history of this disorder, which in many places is quite shameful. In New Zealand, you've got new patient-led organisations beginning, and these are two of them. There are links on the Neurological Foundation website. It's fantastic that these are beginning because everybody needs to understand FND in the context of their own countries. And things are changing. So I've said I was probably the first neurologist to do an FND clinic in the UK, maybe anywhere. This was the first sort of big book about FND, not that long ago, really. And our first meeting in Edinburgh, we made the FND Society. In Boston, we've now got over 1,000 members, and we're having another meeting in Maryland. So things are becoming more mainstream for FND, but we've still got a long way to go. FND's now become a core topic in the European Union training curriculum and in the UK, whereas before it was just invisible. So we are making progress, but for a younger generation of doctors, I think that will be different. But I think for an older generation, it's quite hard to change attitudes and practice very often. We've got these FND pathways. Is one in Scotland that we've just launched, and one in England. So it's definitely, we're becoming more mainstream, but these things take a long time. If any of you took part in our FND and women's health study recently, thank you for that. I just wanted to mention that, because this is a disorder that is more commonly experienced by women than men, although perhaps 1 in 5 patients are men. Where are we heading with research? Well, there's lots of really exciting research going on. This is an example of a study where people were asking the question, can you diagnose FND just by looking at a brain scan, rather than doing these clinical tests that we do? And at the moment, well, not that accurately, but it's definitely a lot more than by chance. So even just by looking at a brain scan, you can tell the difference between somebody with FND versus a healthy control. So that's a really interesting direction. There are new treatments, so we're interested in digital treatments, neurostimulation, including transcranial magnetic stimulation. Virtual reality offers a very interesting way potentially of changing the brain, changing these abnormal brain predictions that get lodged in people's brains. And people are interested in things, other novel treatments is an example here of psychedelic treatments, which may be of interest. We'll find out whether they're helpful or harmful. And we're working out more about what causes FND. Genetics will undoubtedly be important. We're finding out more about how the brain, people talk about the brain and the mind, but it's really the brain, mind, and body. It's all joined up. And this interoception describes the way that your brain senses your own body, which we think is going wrong in a lot of people with FND. And there's research around these kinds of risk factors and comorbidities, particularly ASD, or autism spectrum disorder, ADHD. We think joint hypermobility, which is present in perhaps 1 in 5 of the population, is more common in people with FND. There's a lot of symptoms of autonomic dysfunction, which we need to explore more, and immune dysregulation. So I'm going to wind up. I'm aware people listening to this might be thinking, well, that's all very interesting, but I wasn't referred for therapy. I was just discharged. I can't find anyone to help me, or I'm on a long waiting list for treatment, or I've had upsetting experiences with health professionals that don't match what you're talking about. So I'm just putting this up here to show you I understand that. Or maybe you have had lots of treatment and actually it hasn't helped and things aren't any better. And I understand that too. The treatments that we have help some people, but they don't help everybody. We need better treatments for this condition. Here's our research group having an away day in East Lothian near Edinburgh. And there's a QR code here which will link to some materials if you want to read more about FND. So I'll stop there and look forward to taking some questions. Thank you.
Thank you, John. That was really fascinating, and I think so helpful just to have those videos so that we can all see it for ourselves if we haven't seen somebody having those functional disorders before. It's really helpful to understand what's going on. And one thing that I've heard is that we see things ramping up now in New Zealand as well, and it may be because FND has increased since COVID. Is that something you've heard about or agree with? Do you think there's been an increase?
I'm not sure that it's ever increased, actually. I think what we see with FND, so there was a study, for example, in 1890 by Charcot, who was one of the founders of neurology. He found it was about 8% of his outpatients with neurological conditions. That's roughly where we are now. So I think what we've seen is that people have underdiagnosed FND, and they're now probably recognizing it a bit more and calling it FND, whereas before they would have said, oh, scan's normal, etc. So I think there was we did see a little peak in a particular type of FND called functional tics through the pandemic, particularly in teenagers, which has probably gone back down again. But I think overall, FND is just really common everywhere, all around the world, and always has been, I think, my view.
So we've had someone asking about the link with head injuries. It seems like there's so many different things that can be associated with FND, but is there a common type of head injury that you've seen associated with FND?
So head injury is a trigger for FND in some people, and it's often, I mean, about 95% of brain injuries are mild. So just by sheer numbers, I think mild brain injuries are the commonest. It's an interesting example of what often happens. So after a mild head injury, people have symptoms that they might call concussion, where they feel they've got brain fog, or they're a bit spaced out, or they're a bit unsteady, or they have a headache, feel tired. These are direct consequences of a brain injury, which normally go away. Your brain adapts and you feel better, usually within a few weeks or a few months at most. In FND, what happens is the brain gets stuck. It's as if the brain is responding as if the injury has just happened. It's still in sort of protect mode, and it's thinking, I've been injured. I've got to shut everything down. I've got to keep this person safe. And so symptoms persist, but they don't persist because of the damage. They persist because the software has been mangled by the injury. And we see the same thing with people with migraine, with MS and other conditions as well.
So someone is asking how cognitive functional symptoms are diagnosed, and if you can explain that.
Yeah. So this is a relatively newer area of research, and we've been involved in Edinburgh. What we notice is there are patients with about a quarter of patients in memory clinics and rising have, again, genuine memory symptoms, and they get pretty worried that they may be getting dementia because they're so bad. But what you discover when you talk to them is that under some circumstances, their memories work and cognition's working really well. So you talk to them about their job, and actually the job's going okay, and they are performing okay. But when they do memory tests, when they're focused on their memory, it's not working. So it's a bit like what I showed you with Rachel, that when she was trying really hard to move her leg, the more she tried, the worse it got. Brain was sort of overworking on the problem. And so there are a range of ways for cognition clinical features that we think are typical, and we've got a PhD student working on that at the moment. It will take me a while to tell you what they all are, and you need to put them in combination. So all of these things, it's not just about having one clinical feature. You need to have lots really to be more confident. That's what you're dealing with.
Are there some minor injuries that can cause FND? I know we've talked about brain injury, but other minor injuries?
Yeah. So it's really common to meet patients who've developed their functional motor problems, like functional limb weakness or functional tremor, after a physical injury to that limb. And we saw that in shell shock, that soldiers would have an injury to their leg. And just like the conversation of brain injury, that they have a soft tissue injury or a broken leg or something, and symptoms persist even though the tissue is healed. It's because the injury changes the brain, and the brain gets stuck. So it's the same idea.
I don't know if you'll be able to answer the next question because it's quite New Zealand focused, but it's about our accident compensation scheme and whether FND is supported under that. Do you know anything about that or have anything similar?
Well, I do. Yeah, no, I do. I mean, I was having lots of conversations about this when I was in New Zealand, and I know you've got a slightly different scheme, but it is, and what I'm hearing is a lot of people who a lot of health professionals working in that scheme, seeing a lot of people with FND. Now, I can't tell you whether it's supported. My view is that you should support people on the basis of whether they've got a genuine disability or not, rather than what diagnosis they've got, but maybe your system's different. But I know that it's inevitably going to be there for the reasons we've said. It can be triggered by accidents. But then you're into difficult territory of, well, was it the accident, or was it, I've shown you what a complicated range of factors predisposing, precipitating, perpetuating cause FND. There might be an injury in there, but is that the main cause? That's often open to dispute about whether it was that or whether it might have happened anyway. So that's probably where people run up against difficulties, I would imagine.
Yeah, no, I can definitely see that being, in those sort of organisations, if there's something to get them out of paying, then they will often try and do that.
Yeah.
got somebody asking about similarities between FND and tardive dyskinesia and dystonia caused by antipsychotic medications. Is that something you've come across?
Yeah, different conditions, really, I would say. So tardive dyskinesia doesn't have the qualities of FND in the sense that you can't change it by changing people's attentional focus. So different condition, but it can look super, there are many forms of dystonia, which are not FND, and they can look superficially similar, but they're different. So this is where you need a neurologist. There are loads of unusual looking neurological conditions. So you don't diagnose FND because something looks strange or you haven't seen it before.
Yeah. And in New Zealand, I think FND is first of all diagnosed by a neurologist. Is that the same in the UK? What is the gold standard of treatment?
Yeah, I think FND should be diagnosed by someone with neurological expertise. That might not be, that is usually a neurologist, but doesn't have to be. More important about what expert, it might be a stroke physician or someone who has the knowledge to know about the many pitfalls of diagnosis. So you do have to be careful. I worry slightly about overdiagnosis of FND by non-specialists who are not familiar with how this condition should be diagnosed.
So that would be the gold standard of care would be people going to a specialist according to the symptoms that they have?
Yeah, so person presenting with seizures or with paralysis, tremor, needs to see someone who knows about all the various conditions that cause that, given a clear explanation about why that diagnosis has been made on an inclusive basis, and then a discussion about whether it's the right time for therapy for them, whether sort of over general rehabilitation is the basic idea of therapy. We're trying to retrain the brain by whatever therapies are available to us.
So as a neurologist, you will often do the assessment, but then you'll refer them to different therapists.
Yes, I mean, I think it's important for the neurologist or whoever's diagnosed the condition to stay involved. I think what isn't appreciated is, you've got FND, I'm going to send you off to this person, goodbye. Because, we don't do that when we're diagnosing MS or Parkinson's. We carry on seeing the patient. For many people, they have symptoms that go on a long time. Although I see someone's asked, do patients ever make a complete recovery? The answer is yes, they do sometimes. Symptoms can come and go. It's very varied. And I know that's frustrating to hear if you've got this condition because you want to know what's going to happen. But the outcome is very varied, and don't lose hope of the potential for recovery. However long you've had it, I would say.
Do you know anything about PNES and if that's potentially FND?
Yeah, so this is I think a pretty unhelpful acronym, but it stands for psychogenic non-epileptic seizures. So it's an acronym that we're really trying to phase out.
Yeah,
you can see from the name, it's sort of saying it's all in your mind and it's not epilepsy. So these are exactly the kind of issues that I was talking about, really. So we talk about functional seizures now, a subtype of FND, or dissociative seizures. It's the same thing. Yeah.
I know that you've been in New Zealand at the physiotherapy conference and traveling around talking to people. Do you have any sense of where New Zealand is at on the pathway of improving diagnosis and treatment for FND?
I think it's probably similar to most places. I think where things have moved a bit faster in the UK because we've had people like myself. I think particularly from neurology, if neurology, where the patients are coming, takes the lead, that seems to help drive services. So I think we're still waiting. We could really do with a New Zealand neurologist flying the flag for FND. There are people interested in FND in neurology, in psychiatry, psychology, physio, because I've met them all doing research. So I think things are gathering a bit of momentum. I'm keen to help support any networks in New Zealand that might be arising, and I'm hoping these patient organisations can help with that process, I hope.
Yeah, that would be fantastic, because I know there is definitely neurologists interested and working on things, but don't have the capacity to roll out anything nationwide at this point in time.
Yeah, that's right. I think you're quite short, you know, in terms of number of neurologists per population, you're quite low.
Yeah.
It's kind of the situation in New Zealand's similar to how it was in the UK maybe 20-25 years ago. I was quite surprised actually when I came that it was still, that numbers were so low.
Yes, if I'm ever talking to medical students that haven't decided on a specialisation yet, I recommend that they go into neurology, because that would be really
Absolutely.
helpful for us.
It's a growth area, yeah.
Yeah, definitely. So we're almost up, but there is one question here that I think would be quite interesting to have you answer, and that's about the FND symptoms fluctuating. This person has heard health professionals say that if symptoms fluctuate, then it's psychosomatic and not FND, but I'm pretty sure that's incorrect.
Yeah, it's incorrect. I mean, lots of conditions have fluctuating symptoms. So the fact that something varies doesn't necessarily tell you very much. People with MS, any chronic condition can vary day to day. People with FND sometimes have dramatically varying symptoms where they're kind of normal in the morning and then they're disabled in the afternoon. That can be a clue to FND. Again, that in that question, we see misunderstanding of words and concepts, really. So it's not FND, it's psychosomatic. Well, what do they mean, psychosomatic? Psychosomatic actually means a disorder of the body and the mind together. So you could say that FND is psychosomatic, but the word psychosomatic is so badly misunderstood. It usually means faking or imaginary, which FND clearly isn't. So we're in a real mess with our words and concepts here about these disorders of brain function, I would say.
And the last question, do you see a difference in prevalence for different age groups or ethnicities?
Yeah, for age groups, it's quite interesting that it is a disorder of where it's more common in women, and someone's asked about that. I think the reasons for that are complicated, and they're numerous, and they're both biological and probably psychosocial as well. It's interesting that in children, it's pretty rare below the age of 10. In teenagers and in older people, so sometimes people in their 60s and 70s get this as well, you see a much more even gender ratio. So there's more men in those groups. And there's different ages of onset for different symptoms. So seizures are much more common in people in the teens and early 20s, motor symptoms in 30s and 40s. But it can happen, there's lots of exceptions to that. There's lots of things, rules that this condition doesn't obey as well.
It's such a fascinating condition. I can see we're never going to run out of things to research about it.
No, not. It's good. Yeah, I mean, I did think it would take a lifetime to get to the bottom of this, or perhaps that I would never get to the bottom of it in a lifetime. And it certainly, I agree, it is a fascinating condition. It's an awful condition to have, but a fascinating one as well. And that's, I do want to excite health professionals' curiosity about this condition, and patients too. I think that's an important part of it.
Yeah, I just want to really thank you for sharing so much with us tonight in such a short time. You've packed a lot into your talk that's really informative, and I think it will be informative both for patients and their families, but also for clinicians, just to get some more information about what it is they're seeing and where they can go for further information as well. So we're just going to share some QR codes of some links to different pages that people watching might find helpful, and we'll just leave that up for a couple of minutes so that you can get those down. But I think when the information goes out about the follow-up of the talk, that those links will be sent out to you as well, and this will also be recorded. But I just really want to say thank you to Jon for joining us tonight, and thank you to a great number of people in the audience as well who have taken time out of their evening to join us tonight, and we've really enjoyed having you all here.
Great.